Hi, welcome everyone to our second webinar. As you know, based on your registration, today we will continue with the same topic that we started in our August webinar. We're going to continue talking about complicated monochorionic pregnancies. It is my pleasure and my co-host's pleasure, Dr. Shamsir Saz, to have a wonderful panel of experts that will be talking about different complications in these high-risk pregnancies. So without any further ado, I'm going to let Dr. Shamsir Saz introduce our first speaker.
Welcome, everybody. This is Shami, and welcome to the Fetal Medicine webinar series. I'm honored today to introduce our first speaker, a great friend, Dr. Ramin Schmid. He is the director of fetal intervention in the University of California, South California. Dr. Ramin Schmid is a professor, and he has a couple of courtesy appointments in the pediatric department and the surgery too. Ramin is working in the field for more than 2 decades, and he published more than 150 manuscripts and textbook in this field. He's well known for all of us, and today he will talk about the selective fetal growth restriction type 2A and 2B and what is the management. Thank you very much, Ramin, for accepting our invitation, and we're looking forward to your wonderful talk.
Thank you, Shami and Magda, for inviting me. It's my pleasure, and I look forward to talking to you about a topic that I've been thinking about, as you mentioned, for 2 decades, and that is selective fetal growth restriction. So my plan is to briefly mention some background. Much of this is review for most of the people listening, but then I want to focus on a subclassification of type 2 selective fetal growth restriction. We call it type 2A and 2B, and how we use this subclassification to guide management. And I'm going to present to you the data that we analyze at our center to establish this classification and help us guide management. So briefly, as far as background is concerned, we all know the monochorionic twin placenta has these vascular communications along the vascular equator that link the circulatory systems of the twins together, and it allows blood to be shunted from one twin to the other twin. And that's the pathophysiology of twin-twin transfusion syndrome, unequal sharing of blood from one twin to the other twin. I will not be talking about TTTS. My colleagues on this panel will be talking about this. My focus will be on selective intrauterine growth restriction. However, we all know that the management of twin-twin transfusion syndrome involves laser photocoagulation of the communicating vessels, which you can see here. And the idea is by laser occluding these vascular communications, you separate the twins from each other and stop the shunting of blood from one twin to the other twin. However, in selective fetal growth restriction, the problem is not unequal shunting of blood. The problem has to do with placental share and the individual placental territory of the donor twin. So the pathophysiology is different. So can the management of selective fetal growth restriction be similar to that of TTTS? That's something that I'm hopefully going to be answering later on in this talk. So you all know how to diagnose twin-twin transfusion syndrome. Selective fetal growth restriction is basically not TTTS, so you don't have polyhydramnios and oligohydramnios, but the smaller twin measures less than the 10th percentile. And there's this consensus panel that have come together to help us diagnose selective fetal growth restriction. And Dr. Khalil is an author on this important work, and you can see the method used to diagnose selective fetal growth restriction on this slide. So I like to think about the pathophysiology of complicated monochorionic twins along this Venn diagram. You can have pure twin-twin transfusion syndrome on this side here. And in this side, these babies are normally grown, both twins. Now, you could also have twin-twin transfusion syndrome, but the smaller twin is measuring less than 10th percentile, has fetal growth restriction. We still call it TTS, but it's TTS with selective fetal growth restriction. And on this side of this Venn diagram, these are the pure SIUGRs, where there's no oligohydramnios, polyhydramnios. There could be some fluid discordance, but you don't meet criteria for twin-twin transfusion syndrome, and the smaller twin is very growth restricted. Here is an example where you can see that there's a significant discordance in weight, but the amniotic fluid volume, and maybe discordant as far as visually is concerned, but the maximum focal pockets do not meet criteria for twin-twin transfusion syndrome. I just like to throw in this slide because this is a study that we published in 2016 where we looked at cases of twin-twin transfusion syndrome in which the smaller twin, the donor twin, was normally grown, and we saw that there was equal placental share. That makes sense, right? Because both babies are normally grown. And then we looked at the cases of twin-twin transfusion syndrome in which one baby was measuring less than 10th percentile. And I guess we always thought that there's unequal placental share because the smaller twin has less placenta, because the recipient twin maybe has more placenta. But the reality is when we actually took the placentas and evaluated them, the recipient twin's placental territory was preserved. It wasn't different between these two cases. It's just that the donor twin did not achieve its potential. The placental growth was never robust like the other cases. And so that's just kind of pointing to, I think, we still have a lot to learn about this condition. And why is it that the smaller donor twin's placenta never kind of achieved its potential? It's not that the overall placental size is the same. The whole overall placental size is less because the smaller twin did not grow that end of the placenta. So when we think about monochorionic twins with selective fetal growth restriction, really, as far as the natural history is concerned, as far as clinicians and managing these pregnancies, it's basically a race against time, because you have this smaller twin that's very growth restricted and can deteriorate over the course of the pregnancy. We also worry about the fact that this baby may have an increased risk of fetal demise, and we all know that the demise of the smaller twin could cause a 30% risk of brain damage or death to the co-twin. So management is complicated. How long can you safely prolong the pregnancy to avoid the risks of prematurity, but not allow for the smaller twin to pass and result in potential injury or death to the co-twin? That's the dilemma. This classification for fetal growth restriction by Gradacos has pretty much stood the test of time. There's 3 types: type 1, type 2, type 3, and it's based on the umbilical RA Doppler waveform of the smaller twin. And these are indeed distinct patient populations with distinct natural histories and natural courses. And right now, we're going to focus on type 2. That's the point of this talk. And this is the most severe group, in my opinion. So type 2 selective fetal growth restriction, these smaller twins have persistent absent and reverse end diastolic flow in the umbilical artery. And it's very important to monitor this when you do ultrasound, more than just one capture of the Doppler. I tell my sonographers over the course of an hour to repeat the beginning, the middle, and the end to confirm that there is indeed persistent absent or reverse end diastolic flow. And if that's the case, then we classify that into type 2 SIGR. The natural history of type 2 SIGR has been elucidated over the past 2 decades. And in general, we quote about 20 to 40% risk of demise of the growth restricted twin, about an 8% risk of neurological injury of the smaller twin, and the mean gestational age of delivery at 29 to 30 weeks. That's just in general. What are the treatment options? Here's the list of the pregnancy options that the mother is usually given in this setting. These are patients that usually present at around anywhere between 16 to 26 weeks gestation at our center, and we diagnose type 2 SIHR. We offer expected management, termination of the entire pregnancy, or some kind of fetal treatment, as you see here, whether it's laser or cord occlusion. So expected management of selective intrauterine growth restriction with persistent absent reverse end diastolic flow. The dilemma is, I mentioned earlier, timing of delivery. How far can you prolong this pregnancy safely? And basically, with expected management, the risk of prematurity is 100%, unless, God forbid, the smaller twin does pass. At that point, the damage is done, and you might as well prolong the pregnancy as long as possible. The laser surgery, as I mentioned to you before, involves separating the twins together. It doesn't necessarily solve the problem of placental share, but it unlinks their fates. And by unlinking the fates of the twins, it allows the doctor and the patient to negotiate how long they can safely prolong the pregnancy, understanding the fact that there probably may be an increased risk of fetal demise of the smaller twin, but at least you don't impose the risks of prematurity on both twins. And that's the concept of laser surgery. It's a sophisticated conversation that must be done between the doctor and the patients, and they kind of have to be on the same wavelength. The justification for laser surgery is that by doing the laser surgery, you can prevent possible injury or death to the appropriately grown twin. And so in some ways, you can think of this surgery as potentially prophylaxing against the possibility of injury or death, as well as prematurity. Now, the problem with the laser surgery is it's technically very challenging. You don't get the severe oligohydramnios and polyhydramnios to allow for surgical access to the vascular equator. So it's technically challenging, but there are tricks. And with experience, it's definitely technically doable that we've found. So going back to this Venn diagram, over the course of several years, as I've been managing these complicated twins, I've noticed that after laser surgery for twin-twin transfusion syndrome, the smaller twin that are normally grown have an 84% chance of survival at our center. Now, if they have twin-twin transfusion syndrome, but the smaller twin is measuring less than a 10th percentile, there's a little drop in survival, but still it's 75%. Now, if you have twin-twin transfusion syndrome and the donor is growth restricted and has persistent absent or reverse end diastolic flow, it drops further. Now, what if you're on this side of the spectrum? What's the survival rate after laser if you have just fetal growth restriction? That was the question I had several years ago. In the case of the recipient twin, regardless where they are on the spectrum, the survival rate was around 90%. So we did a prospective randomized trial. We felt that it was ethically justified because there's potential equipoise between expected management and laser surgery. Each has their own technical problems. So we did a randomized controlled trial that we published this year, 2021, where we compared patients with type 2 SIGR who are randomly assigned to either laser versus expected management. And we published it this year after we got neurological outcome data. So these children were born and are over 2 years, and we did a Fetal developmental inventory on all survivors, and we looked at the neurological outcomes of those patients that are randomly assigned to laser versus expected management. Basically, the neurological outcomes in the appropriately grown twin were about the same, 97 versus 98, 100 being the median. In the smaller twins, it was 72 versus 92, but we had very small numbers. We only had a total of 20 patients, and we had to interrupt the study early because we were not able to complete the study because of poor enrollment. So there was essentially no difference between the two study arms, at least statistically. One thing that we did find was that there was a statistically different gestational age at delivery. So those that were randomly assigned to expectant management and sent back to their respective centers end up being delivered at 28 weeks because of this deterioration that occurred over time. And the doctors basically said, well, you have to deliver. Whereas if they had the laser surgery, because we created a functional dichorionic twin gestation, it allowed for the possibility of continuing the pregnancy. So these babies end up being delivered on average at 33 weeks gestation. So now we can start filling in this table. So we basically found that after laser surgery for type 2 SIGR, the survival rate for the smaller twins was around 30%. Now that's not great. It's still relatively low, but it's better than zero if you're going to do a cord occlusion. Again, there's technical issues with the laser surgery, and that may also color as far as counseling. If it's technically difficult, it may be easier to do cord occlusions, and that there is something to be said about that. Essentially, cord occlusion of a smaller twin is technically much more achievable than doing laser surgery. Now, this is to me the most important part of this talk, and I'm going to spend another 2 minutes or so talking about this aspect. At our center for the past 2 decades, we could not offer cord occlusion for type 2 SHR. It was not possible. So patients were either allowed expectant management or underwent laser surgery. So what did that do? Inadvertently, I guess, it allowed us to do a natural history study of laser for type 2 SIGR because there was no pop-off valve. There was no cord occlusions. These all underwent laser surgery. So we went back and looked at all the patients that underwent laser surgery to see if there was patients that were ideally suited for laser. And we went from 2006 to 2018 and looked at all of our cases that underwent laser. We had 45 patients, type 2 SIGR, that underwent laser, and we looked at survival rates. After laser, 30 days after birth, most of the appropriately grown twins survived, 93%. The growth restricted twins, about 35%. We already knew that. About a third of the smaller twins survived after laser. Now we looked at potential predictors of who would survive after laser. And I mean, this is nothing that you wouldn't expect. The sicker the smaller twin, the lower the chance of survival. So if the middle cerebral artery peak systolic velocity was greater than 1.5 multiples of the median, which is basically just a surrogate for centralization of flow in these twins. It's not anemia, it's just centralization of flow because these are sick kids. Those babies had a lower chance of survival after laser. Also, if you had abnormal flow in the ductus venosus, you had persistent, absent, or reverse flow in the ductus venosus, those kids had lower survival after laser. So, I mean, this is not shocking. These sicker twins after laser had a lower survival. If they had normal MCA Dopplers and normal ductus venosus, they had a higher chance of survival. So that allowed us to subclassify type 2 SIGR into type 2A. So type 2A have persistent absent end-diastolic flow in the umbilical artery, but normal flow in the middle cerebral artery as far as peak systolic velocity and normal ductus venosus waveforms. And type 2B had middle cerebral artery peak systolic velocity greater than or equal to 1.5 multiples of the median and or absent or reverse flow in the ductus venosus. So now we can subclassify patients into type 2A and 2B. What did we find when we did that? Of our 45 patients, 32 of them were type 2A and 13 were type 2B. And if you were a type 2A, 50% of those smaller twins survived after laser surgery. That's to me, that's a reasonable number. If you tell a mother that we could do laser surgery and then there's a 50% chance of survival of the smaller twin, who would be neurologically equivalent to the appropriately grown twin, to me, that's a reasonable number. But if you're type 2B, in our hands at least, none of those babies survived after laser. and that was significant. So basically, we proposed the subclassification, which will help guide management. If you are a type 2A, normal MCA peak stalk velocity, normal diagnoses waveform, versus type 2B, in which one of those two are abnormal. At our center now, because of the study, we offer laser surgery and we counsel the patient that there's a 50% chance of survival of the smaller twin. But if they're a 2B, at our center, we now offer the option of cord occlusion, which we never did before. So there was personal and ethical reasons why we never did cord occlusion. But when we found out that the chance of survival was so low, to me, ethically, it was justified to do cord occlusion. Now, I want to caution you that this is one study, and we look forward to other centers contributing to this data. But at least in our hands, type 2B, after laser, we had no survivors. So basically, we now at our center prospectively classified type 2 SIGR into type 2A and 2B, and we use that to help counsel and guide management. Thank you.
Thank you very much, Rami, for the wonderful talk, and also, for an interesting finding, and hopefully we can confirm what you find on the type 2B in the near future. And with that said, it will be pretty helpful for choosing the option and the best management for this group of the patient. We are going to introduce the next speaker. This is Dr. Rupali Donapudi. She is a friend and a colleague, and we are working in the same division. We are fortunate to recruit Dr. Donapudi back in 2019, and she was a wonderful addition to our team. She had more than 50 publications in the area of the fetal intervention, and she's a very passionate for education. She's the Associate Director of Maternal Fetal Medicine Fellowship and also Associate Director of the Fetal Surgery Fellowship. She's almost an advocate for a patient, and she's very passionate for patient care. With that said, again, we're looking for Dr. Donapudi to talk.
Great. Thank you so much, Shami, for that very kind introduction. And thank you to both Magda and Shami for inviting me to talk today. It's really such an honor to be amongst all the other panelists who are such amazing people personally and great work in the field. I have no disclosures today. So the first couple of slides are going to be a little bit of similar stuff to Dr. Schmid. Hopefully, I'm not going to get too much into that area, except for the part where it does overlap a little bit. But as everyone knows over here, obviously, monochorionic twins, the reason we get so concerned about it is because these are twins where the placenta, there's vascular connections between the two fetuses. And this is obviously seen in 100% of these fetuses, but they do have a risk for complications, and these are the ones that are going to be addressed today. I'm going to talk a little bit about the twin-twin transfusion with selective fetal growth restriction overlapping twin-twin transfusion syndrome, and you'll be hearing about twin anemia polycythemia and twin reverse arterial perfusion later in the session. So very briefly, as Dr. Schmid had mentioned, with selective fetal growth restriction, it can occur from either the TTTS that's underlying, that's part of what you have a mixed group where you can have selective fetal growth restriction with TTTS, or you can entirely have selective fetal growth restriction as a result of the placental share, the imbalance there. And as you can see in this wonderful image from prior publications, that you can see that the fetus with the cord insertion on the left is a velamentous cord insertion. It has very few vessels. It has a very small portion of the placenta. And naturally, that fetus is growth restricted as compared to its co-twin, which occupies a bulk of that placenta. So again, not to belabor this point about the Graticose types, which, as Dr. Schmidt mentioned, is pretty much what most places use, and we as well follow the classic Graticose types, which are type 1 with the normal UA Dopplers, 2 with the abnormal persistent Dopplers, and 3 where it's intermittent. So why are we concerned about it? Well, the biggest risk is because if you do nothing and there's a demise of one, it obviously can cause damage or demise of the co-twin. Well, the biggest problem that I find is how do we define selective fetal growth restriction? And I've had the pleasure of moving around quite a bit in the country. Maybe I'll move to Europe at some point and go through that confusion as well. But, you know, as we all work in different areas, we all tend to classify growth restriction a little bit differently. And so that's led to a lot of the confusion over the years, where ISWA has recommended classifying it as the fetal weight of one twin less than the 10th percentile with a discordance between the twins greater than 25%. However, we find that other centers use different definitions. Some places use the EFW of either twin less than 3rd percentile. Some use either twin less than 10th percentile. Some use purely the discordance of greater than 25 percentile. And as mentioned earlier, Dr. Khalil being one of the first author for this amazing publication, where they did the Delphi consensus, and they found and they looked at different definitions, and the addition that they had to what I already mentioned was if we pick the 2 out of 4 criteria, which includes either twin less than 10th percentile, the AC of either twin less than 10th percentile, discordance greater than or equal to 25%, or a UA pulsatility index of the smaller one, a greater than 95th percentile. So as you can see here, there are so many ways to define selective fetal growth restriction. So that obviously adds to the confusion when we start talking about who's selective growth restriction, what are the outcomes, how does it make a difference in one patient versus the other. So going back to the original thing, so twin-twin transfusion syndrome. Now, you know, it used to be that this is such a straightforward thing. You know, it's a classic definition, and thanks to Dr. Quintero, the definition is very well known by everybody. But just to rehash, stage 1, as you can see over here, is where you have a discordance in the fluid. There is oligohydramnios in the donor fetus, where it's less than 2 centimeters of the MVP, or you have polyhydramnios in the recipient fetus, where the MVP is greater than 8 centimeters in the US. I know in Europe, it's different based on gestational age. Stage 2 is when you have an absent bladder in the donor. Stage 3, as you can see over here, is when you start seeing the Dopplers becoming abnormal. So you look at the umbilical artery and the ductus venosus, and if you start seeing absent or reverse flow, they qualify as stage 3. Stage 4 is when you have hydrops of either fetus, and hydrops, as we know, is classified as a fluid collection in 2 or more spaces. So if you start seeing ascites, pleural effusion, pericardial effusion, skin edema, then they qualify as stage 4. And of course, stage 5 is the death of one or both fetuses. So I'm not going to go back into how we came about doing the laser surgery, but as y'all can see, you know, serial amnion reduction is no longer the primary management. It's only done in select cases, but typically it's done along with placental laser ablation. So looking specifically at placental laser ablation, I will say this has come a long way. The quality of the scopes has changed quite a bit, and so the techniques have been modified a little bit, but it's really amazing to go back and when I was a resident, seeing how things looked, and now it's quite refined. So in selective laser ablation, what we do is we insert a cannula, as you can see over here on the left, into the recipient's sac. The size of the cannula obviously depends on the placental location, the gestational age. You know, we try to use the smallest cannula possible to reduce the risks of membrane separation or PPROM or preterm labor. But once you insert you put in the cannula, you insert your scope, and the goal is to get down to the placenta to find all our vascular anastomoses and then laser coagulate these anastomoses. And based on the Solomon trial, we've also incorporated doing solemnization, where you can separate essentially the two placentas, so there's no longer any vascular communication between the two. I know nowadays there are some centers that plus or minus Solomon based on how well you can visualize these things. And like I said, the scope quality has come a long way. And so we definitely have better visualization now. But for the majority of the cases, after we do individual vessels, we will do the solemnization to make sure we don't miss any of the tinier vessels. So this is based off of our data. So it's on our website. We are more than happy to share our outcomes with everyone. So as you can see over here, we've broken it down based on the stage of TTTS, and we've also broken it down based on gestational age. So what you find over here is as you get further in the stage of TTTS, the outcomes are going to drop a little bit because these are fetuses that obviously are sicker prior to going into the surgery. But also interestingly, as you look at gestational age, traditionally the earlier you intervene, we are concerned about the risk for PPROM and membrane separation, but we haven't found a significant difference in that. But definitely we do tend to get more concerned if we have to intervene earlier. Well, what happens in these in some special cases? So we went back and looked at some of our cases, and we find that sometimes it's not as straightforward. Like I said, you have a little bit of TTTS. So you can see there is a fluid discordance here. This baby is stuck on this side. You can see that over here, it's not moving anywhere. And then you have the other fetus. But when you actually measure your MVP, you tend to find that earlier gestations, say around 16 weeks, you have no fluid in one fetus, but you tend to have around 6 or 7 centimeters in the other fetus. So now the concern is this TTTS or not? Well, logic will tell you this is definitely going in that direction, but what makes us start a little bit earlier? So when you investigate a little bit further, we found that the fetus that has less fluid also has a smaller or lower fetal weight. So we're having a reduced fetal weight, reduced fluid, and then you start seeing abnormal Dopplers. So this is one of our typical presentation where you have selective fetal growth restriction, and now you're kind of having borderline TTTS as well. And this tends to be, I will say it's probably a testament to the better screening that we're doing nowadays, and the implementation of protocols, and most centers adopting early implementation of these protocols to screen. But we are finding more and more that you're finding this in-between gray zone where you have some amount of selective fetal growth restriction and now some amount of the twin-twin transfusion. They do go on to declare themselves, and you will end up seeing that the amount of fluid discordance will go up over time, where you will start seeing that the larger, the recipient twin will start having 8 or 9, or then it meets the classic definition. But early on, you'll see that the first thing that ends up presenting is the selective fetal growth restriction. So there is this middle group that's not going to meet exact criteria for TTTS, that's not exclusively selective fetal growth restriction, but they do tend to have a combination of both. So what happens when you have this combination? Well, the concern is that typically it affects the donor. The survival rates tend to be lower for this growth-restricted donor fetus. And you obviously, as mentioned earlier with the selective fetal growth restriction, you tend to see more of the velamentous cord insertion. And these fetuses that have a combination of TTTS and growth restriction do tend to be the ones that have abnormal Dopplers. So you see a lot of publications like this where you find that, yes, there's more donor demise with growth restriction. The question is, everyone has a different definition. So does that play into whether there's a risk for demise or not? And so we did a study a few years ago where we actually utilized the different definitions that I had mentioned, and also the Delphi consensus. And we wanted to see if based on your definition, does it really change how much donor demise you have? Are we overanalyzing this? Are we overthinking it? And what you find is, based on your definition, the number of people who tend to qualify as TTTS with growth restriction obviously changes, right? The more inclusive your definition is going to be, the bigger, the more that you're allowing to be classified here, you're going to end up finding more patients. But you do see actually similar risk for demise. You see 24% versus 23% versus 28%. So no matter which definition you use, if you have a growth restricted fetus and if you have abnormal Dopplers, you're more likely to end up having a donor demise. Well, why do we care so much about all this? Well, it obviously makes a difference to the parents, because as you're counseling these patients, when we use the classic TTTS, where you have a pocket of 15 centimeters on one side, no fluid on the other side, you're going to have better outcomes, and you're going to have a higher chance of having 2 live fetuses. But if you go into the surgery with significant growth restriction, it's obviously better to let the parents know that the risk of this smaller fetus passing away or not making it through the surgery is going to be higher. And so for us, it's very important to know who are those patients who are going to fall under this category and what are their risks for this donor demise. So as I said earlier, depending on which classification, which definitions you use, you're going to be more inclusive or not. So your sensitivity is the highest when you use the 2 out of 4 criteria by the Delphi consensus, but obviously you're compromising your specificity if using that particular definition. So based on your definition, you're going to have varying levels of sensitivity or specificity. So I'm going to put a shameless plug here, because this question continues to bug us on some level, and it is something that we're really, interested in trying to figure out, get to the bottom of which patients do worse than others. So I hope you all join the ISWAG annual conference this year, and it's virtual, so hopefully it's possible for most people to join. But we do have an oral presentation on looking at some more about these predictors for growth restriction. And so just one point about that, I can't give you too much of the results, but the amount of growth discordance does make a big difference. So regardless of whether you went by ISWAG or anything else, if you just purely took individual parameters, you just individually took the amount of growth discordance, that actually helps you predict the risk of a donor demise. And what's also important, and what we'll be presenting in this presentation at ISWAG, is not just after surgery. The important thing for parents is, what are the odds of you being able to take your baby home? And so the other risk with these surgeries and with these smaller babies is you're going to have preterm delivery. And are these fetuses going to make it out of the NICU and go home with you? So some of that is going to be presented there. But like I said, the growth discordance does play a big part into it, even more so than just purely looking at abnormal Dopplers. So the concern that we have, as I mentioned before, when you use a combination of, when you see these patients with TTTS and growth restriction, the fluid discordance tends to be less apparent. So from a technical point of view too, this surgery may be a little bit more challenging. It's definitely obviously doable, but when you have less polyhydramnios, you just barely meet criteria for polyhydramnios, there is a higher risk for membrane separation, for chorion-amnion separation, and a slightly higher risk for PPROM. And this has been shown in several studies in our cohort as well. And so that does make it technically, obviously, a little challenging in terms of the outcomes. You can definitely, infuse some fluid, but it does, no matter whether you infuse or not, once you enter with the lower pressure, it does increase that risk. The other problem is the placenta. Usually when you have significant polyhydramnios, you will find a nice thin placenta, and it almost is like perfectly laid out vessels for you. But when you don't have as much polyhydramnios, which tends to be in these cases, you will find that the placenta is thicker and more scalloped. And so those cases, it is sometimes more challenging to find the anastomoses in this particular type of placenta. So there are some technical difficulties with this as compared to a straight, plain old TTTS. Still doable, but this also goes into our counseling for the patients. So in conclusion, I just wanted to rehash again that donor demise does increase when you do have TTTS complicated by selective fetal growth restriction. The more the intertwin discordance you have, the more significant the discordance is, obviously the higher risk for the demise. You see demise after surgery within 24 to 48 hours as well. But when we're talking about demise, we are also concerned about how many of them make it to delivery and survive to being discharged home. And I just wanted to say thank you again for inviting me for this talk. And it is a big team, and everyone knows that with fetal centers, it takes a lot of people to put this all together. So I just wanted to take a moment to acknowledge our team. And please forgive me if I forgot anyone on here, but like I said, it does take a lot to put these cases and patient care and everything together. Thank you.
Thank you very much, Rupali. Great presentation. And we are also looking forward to see your oral presentation in EastWalk in October. With that said, again, the only question that I'm seeing here is regarding the cord occlusion option allowed in Texas and a state with similar laws. Unfortunately, with the new, Texas law, we are not allowed to do the cord occlusion at this point. And the only, reason of determination will be a maternal reason, not a fetus reason. I don't see any other question and at this point, but I will encourage people to put the question. And, with that said, I give it back to Dr. Cortez to introduce our next speaker.
Yeah, but Shami, before I introduce the next speaker, I just wanted to ask a question to Raman. I think that it's very important, especially for those of us who manage monochorionic pregnancies, and that we have the complication of the diagnosis of selective fetal growth restriction for these families, that when it's TTTS, it seems like things are easier for us because we know if it's an indication for laser versus not an indication for laser, and there's no gray zones there. It can be more technically challenging or less, but you know when you need to go. With selective fetal growth restriction, it's like one of those challenging situations in our practice. So that's why I would like to thank you, Raman, for conducting. We know how difficult it is to do randomized control trials in our specialty, so that you started that study and you published your results. And I think that it's very good to have the sub-classification into the type A and type B. So I just want to make an important note of this, because since 2007, when Gratakos published that, back when he was collaborating with the people from Belgium still, there has been a lot of small publications on the matter of selective fetal growth restriction, but still, we don't have a lot of clarity about how to manage type 2 and then type 3, which is another different subject, right? Mm-hmm. So I wanted to ask you about the subclassification. One of the criteria for B is to have an MCA peak systolic velocity equal or higher than 1.5 MOM. We will be talking asthma. We will be hearing asthma talking about TAPS. So what I'm understanding from your classification of selective fetal growth restriction type 2B, which are the ones that don't survive after a laser, those are the ones that have anemia, or what we think that could be an anemia, but you don't expect for the other criteria to define TAPS. You're not demanding for that situation to have polycythemia in the other baby. So you think that if a baby has elevated peak systolic velocity just by itself without the ductus venosus abnormalities, that would be already a strong indicator that that baby might not make it after the laser. Is that right? Can you comment on that?
So that's a very good question, because now there could be, like you mentioned, this subclassification of SIEGR type 2 into 2A and 2B will help the patients and the clinicians as far as thinking about management options and potential outcomes with each management option. But now there could be some ambiguity, because what if you had TAPS with a growth restricted twin? Are you really now talking about a different disease entity? But in my opinion, TAPS is a completely different situation that happens further along in the pregnancy. And most of the time, I mean, it's possible, but most of the time, the smaller donor twins don't have persistent absent diastolic flow. It's not the same pathophysiology where you have these very growth restricted twins early on in their pregnancy that are type 2 and have the MCA elevation. With the new, and we're going to probably hear more about it, the new diagnosis of how to do TAPS in the delta, I worry about, depending on which delta you check to see the discordance in the MCA peak stalk velocity, what threshold you use, that there could be patients that are thrown in there that could be classified as TAPS. Is there a cross between these two entities? It's possible, but in my opinion, in these patients that I'm talking about, these are not TAPS patients. And I've been in there, I've seen it. Pheoscopically, many times those smaller twins are very pale, but the other one is not polycythemic. So I don't know if it's just that these kids are very vulnerable to anemia or what, but I don't think that we can say that this is a TAPS problem. This is a SIAGR placental insufficiency problem. But I think what you're trying to say is if you give a rubric to a clinician, there could be some confusion. Which checkbox do you put this patient into? Because this baby has an elevated MCA peak stalk velocity, and the first thing people are going to think of is TAPS. But what in this disease process, what that's really reflecting is that this kid is very compromised and is centralizing flow. Now you may say, why didn't we use the resistive index? Why didn't we use the pulsatility index? It was a matter of how we established our data and how we use our data set. But the first step is to diagnose type 2 SIAGR and then to subclassify. So I think you'll end up going down a different road. Did I answer your question?
Yeah, absolutely. And it kind of echoes a feeling that I've had, just anecdotal. I obviously haven't done the type of study that you just presented, but I had the feeling that when the peak systolic velocity or even the pulsatility index is very reduced in these babies, that could be also indicative of like a severe degree of deterioration going down the road in selective fetal growth restriction type 2. So to me, it makes sense. Obviously, I'll be looking forward to reading more studies with larger sample sizes because 13 cases is a very small number. But that's super interesting. And I think that if this is the beginning of like some guidance into having more clinical features of what works and what doesn't work for this population, I think that that's really helpful. And the other question that I have for you, Raman, based on the randomized control trial that you presented on selective fetal growth restriction type 2, that you randomized to expectant management versus doing laser. And the main results that you obtained was that the expectant management group were delivered at 28 weeks versus the laser group that were delivered at 33 weeks. That's a big difference. That's a lot of NICU day stays. That's significant. Although it didn't have like a repercussion on the neurodevelopmental outcomes, I think that just having not such a strong degree of prematurity is a big trigger for us to change our practice. So having all of these people listening to us that might detect these cases or that might perform lasers, do you think that the results in your study are sufficient for them to consider in all selective fetal growth restriction type 2, if it's technically feasible to offer a laser considering your results?
So short answer is yes. The short answer is yes. But I would say that it will require one component of it. It's hard to reflect in a randomized controlled trial, but is to have buy-in by the patient and buy-in by the referring doctor. Because you need to inform the referring doctor, assuming that you feel like you had a technically successful laser surgery, that this is now a functional dichorionic twin gestation. And that if you are at 28 weeks gestation and the smaller twin appears to be deteriorating, that you and the mother have discussed the possibility that the smaller twin will suffer a demise in utero. And while tragic, it will not cause harm to the co-twin, and it will allow you to prolong the pregnancy. And the reality is we are very poor at predicting when the smaller twin is going to pass. It's like playing a horrible game of chicken. I don't know if this translates to European, but in America, there's this tradition in the 1950s of two cars coming very close together, and at the last minute, whoever moves first is the chicken. It's a stupid game, but that's basically what we are doing with these pregnancies. You are trying to use imperfect data to impose the risks of prematurity on both twins. So if you do a successful laser surgery, you can have a discussion, a sophisticated discussion, and each patient has different value systems and will have a different buy-in. But you may say, listen, until 32 weeks gestation, we are not going to do a premature delivery, because if the small one were to pass, it will not cause harm to the co-twin. And just because you deliver at 29 or 30 or 31 weeks does not mean that the small twin is going to survive outside of the womb. All you did is impose the risks of prematurity on the bigger twin. Mm-hmm. But if you don't have that laser surgery, you don't have that security. You don't have that security, and you have no choice. Mm-hmm. For clarification, the patients that underwent expectant management were not managed by us in the randomized control trial. They all went back. So we did not tell them when or when not to deliver. They were delivered by their own clinicians. Mm-hmm. We went back and found out the gestational age of delivery.
Can I ask a quick question?
There's another question from Dr. Ahmad Nasr regarding would you consider using MCA-PI less than a 5 percentile as an evidence of brain redistribution in fetal growth restriction fetus?
So we did not collect our data in that way. And so I can't answer that question as far as it pertains to this topic. So the data that we collected for this study was prospectively entered into our database. I could go back retrospectively and find out that answer because we have the actual source data still, but for the purposes of the study that was published, we have a data entry person who prospectively enters the data, and this is not how the data was entered.
And before Polly asks a question, there's a question is from Lucas Otano for any one of the speakers during a fetoscopy for selective IUGR. How do you manage vessels that cross the membrane and due to the amniotic fluid in the IUGR twin? I think it's coming down to you, Ramin, as a technical aspect of the lasering.
Sure, I'll be happy to, and of course, I look forward to my colleagues to contribute. Of course, because there are technical challenges. There's no question, and this does play a role now for us because cord occlusion was when you have no other option. It forces you to use what you have and try to make the best of it. So we could not do cord occlusions at our center until the study for various reasons. So we had no choice but to offer laser. And over time, we just found some tricks. In the case of the hypothetical that was presented, we have two choices, and we've done both of them. The less dramatic choice is to put a needle into the sac of the growth restricted twin and to do an amnio reduction, of course, trying to avoid a septostomy of the dividing membranes, which would sabotage your efforts. And you can create oligohydramnios to allow the dividing membranes to fall back down on the placenta so you can follow those vessels. That's the option I prefer. But sometimes, and you can often identify the situation on ultrasound. Like, for example, If you have a placenta and there's a central cord insertion and a velamentous cord insertion, and you see the divide membranes is coming down right next to the central cord insertion, you can, in your mind's eye, you could tell yourself, you know what? Every single vascular communication is going to be on the side of that growth restricted twin. Why bother entering the sac of the bigger twin, who actually has a higher chance of survival? And you're just gonna, if there's PPROM, that's the kid that's gonna PPROM. So don't even enter that sac. So in those cases, I will put a needle into the sac of the appropriately grown twin, do an amnio reduction, and then do an amnio infusion in the smaller twin to open up that sac. And then all the vascular communications are right in front of you, and you can laser occlude them. I've done both options in the same case before. When some vessels were on one side, some communications on one side, some communications on the other side, and I've had to create oligohydramnios and then polyhydramnios in one sac. So these are technically much more difficult than lasers for TTTS. So that's something that each individual center needs to think about. I would say that if you're like a newer center, there's no question that you should first focus on doing laser surgery for twin-twin transfusion syndrome. Maybe after the first 100 or couple hundred, then maybe think about going into this area.
I think that you made a very important point. Like lasers for selective fetal growth restriction are not as easy as lasers for TTTS, and definitely they're not beginner level. So it's something to think about a lot before you put that patient in the OR table to do a laser. Asma, do you have a comment or a question that you want to make about this?
So yes, maybe a question to Raman. So you presented in your data, and also from experience, that sometimes after the laser for selective fetal growth restriction, the larger twin is the one that demise. What do you think the mechanism of demise of the larger twin in this instance?
That's a great question. So if you look back at that study I presented at the end, there was a 93% chance of survival of the appropriately grown twin, which means that there's a 7% risk of demise. And that has to do most likely with the risks of the laser surgery. PPROM, preterm delivery. So you could do a technically wonderful surgery, but then the bag of water breaks at 22 weeks and then you lose both babies. That's probably the highest reason for and extreme prematurity. So if the babies were born like at 25 weeks and the small and the larger twin passes. But basically, this surgery is, in some ways, it's interesting to think about. It's potentially helping both twins because expectant management, like I said, there's a high risk of prematurity. If you do cord occlusion, there's a 0% chance of survival of the smaller twin, obviously. And still, we know with cord occlusion, the survival rate of the bigger twin is not 100% after cord occlusion. So laser may be the best option because it allows for the bigger twin to have a relatively high chance, 93% chance of survival at a higher gestational age, and you give the opportunity for survival of the smaller twin. Because otherwise, cord occlusion, the chance of survival is 0. So there is no perfect answer, which makes it less satisfying than twin-twin transfusion syndrome. You do laser for TTDS, and you see these mothers holding 2 babies that are appropriately grown and they're delivered at term, and everybody's happy. And type 2 SIGR is not that same situation. You're picking an imperfect treatment option. And again, I go back to you have to counsel the patients so that expectations are understood. But in my opinion, the laser gives you the best opportunity for the best outcome for everybody, including the mother who doesn't have to make that decision, which is a very difficult decision for a mother to know that at least she tried to help both babies, but the small one didn't make it. It wasn't on her hands that the small one did not make it.
So yes, I entirely agree with you, but my question is not the mice with the larger twin, not related to prematurity or miscarriage following the laser. You come across cases where actually the pregnancy continues, but continue with the smaller baby, which is a lot smaller with abnormal Dopplers, very poor prognosis. And in fact, the larger twin is the one that demise after the laser. So my question is that why would the laser actually kill the larger twin?
I have not had that experience in which we did laser and the smaller one survived and the larger one did not. That has not happened to me personally, but I would wonder if the vascular communications were not appropriate, like you cut off the bigger twin in that case, or it could be a prematurity issue, like 25 weekers. Sometimes the smaller twin is more stressed and has a higher survival rate sometimes of extreme prematurity. They do, at least initially, they seem to transition better than the bigger twin. But I don't think that we've seen that where the small one survived and the larger one did not.
Thank you.
Hey, I just wanted to make two really quick points to that, because I know we have to move on, but I just wanted to make the point about the gestational age, because, in Texas, and I'm sure, you come from a hospital where cord occlusion was not an option for a long time personally. And I guess the hospital, I'm not sure if it was their regulations, but similarly in the South, even if you did the laser, I find this more challenging that patients don't want to accept the risk of losing even the smaller ones. So then it comes down to your neonatology colleagues. So that's another area that's challenging. So I do appreciate you bringing up the fact that this is an ongoing discussion with the parents and the referring providers, because, we've been lucky to have really amazing referring providers who constantly will keep you updated about what's going on. And this is an ongoing battle. You have patients always say, I don't want to lose even one baby. And so if it's prematurity for the big one, I'll accept that, but I don't want to lose even the smaller one. And so it's a very common theme in the South. And so that's something to keep in mind as well. But the laser does give you a little bit of that leeway to play with. But the other point in the TTTS with SIGR group, the larger one does have that risk sometimes, because we overlook the fact that the larger one could be sick, right? Just because they do have the risk for the cardiac changes, which unfortunately, doesn't get incorporated in the Quintero staging. But that's the importance of doing the echo and all the other echo parameters, because we have had a couple of times where the recipient twin is, sick, and you see even after the laser, they still have significant TR, and they're still going on to be the ones with more morbidity postnatally. So that's something to keep in mind. We're always focused on this growth-restricted donor twin, but the recipient does have some of that as well. But I don't want to take up too much time. I know we need to move forward.
Thanks, Rupali. I would like to extend a little bit this discussion in the Q&A box. So for our participants, the people in the audience, I would like to ask them who offers laser for selective fetal growth restriction. So if you are one of those people in those centers that offer laser for selective fetal growth restriction, please leave us a comment and just say under what circumstances, how many have you done, etc., so that we can talk about that at the end of this session. And I'm going to move forward with the next speaker. It is my pleasure to introduce a friend and a peer, Professor Asma Khalil. I'm sure that most of you know Asma. She's a professor in obstetrics and gynecology in fetal medicine in St. George Hospital in London. She is the lead for the twin and multiple pregnancy service at that hospital. And she also leads the reproductive health research group at St. George Hospital. She has more than 400 publications. And as you know, she has been leading some of the ISUO guidelines. One of them she's going to be talking about today. And it is my pleasure to introduce her talk today, TAPS, Recent Evidence and Guidance. Thank you so much, Asma.
Thank you very much. It's a pleasure to be here, and thank you for inviting me. Hello, everyone. It's my pleasure to talk to you today on TAPS, or twin anemia polycythemia sequence. So regarding the diagnostic criteria, it started or described by a Dutch neonatologist, Enrico Priori, back in 2010 as postnatal diagnostic criteria with a large inter-twin hemoglobin difference of more than 8 grams per deciliter plus either reticulocyte count ratio of about 1.7 or very small vascular anastomosis in the placenta, as you can see in the picture on the right-hand side. About the antenatal diagnostic criteria, well, anemic twins, so that's MCA peak systolic velocity above 1.5 mom, and for the polycythemic or the recipient less than 1 mom, as you can see here, quite large discordance on the MCA graphs. How accurate this diagnostic criteria? If you look at the one I just mentioned to you, the traditional diagnostic criteria, 1.5 and less than 1, the specificity is 100%, the sensitivity is 46%. So when you actually find them on the scan, the babies do have TAPS, supposed to be the value of 100%, but you might miss a significant proportion of cases of TAPS. 2019, the Dutch group, the same group that described the original criteria, actually came up and say, well, if we use the delta, the discordance of with a cutoff of 0.5 mom, you improve the sensitivity from 46% to 83%, and you maintain specificity of 100%. In the same year, the German group by Kurt Hecker suggested even a lower cutoff of delta or the discordance in MCA peak systolic velocity of 0.373 mom, and then increase your sensitivity further to 93% with a mild reduction in specificity to 96%. So you pick up most of the cases of TAPS and you have a small, almost false positive rate. Therefore, that's the potential for confusion. Which diagnostic criteria should we use? And therefore, we wanted to reach a consensus, and we used the Delphi methodology to develop a consensus on the diagnostic criteria of TAPS, and the results were interesting. The experts voted for almost criteria that would help you to identify the more severe cases of TAPS, and I think it's because there's still sort of some question marks about the natural history of TAPS and also about the best management option because we don't have randomized controlled trial. So the results were the fact that the diagnostic criteria of TAPS were donor of or the anemic twin, peak systolic velocity of 1.5 more standard, but the recipient, they used a lower cutoff of 0.8 mom instead of the 1 mom. Also decided to take into account the discordance, but not the 0.5 or the 0.3 mom, higher cutoff of 1 mom. How about the staging? So similar to TGS, there is a staging for TAPS. And you can see the stage 1 that based on the traditional or the original diagnostic criteria, 1.5 and 1. And stage 2, more severe, so 1.7 and 0.8. Stage 3, once you have evidence of compromise, particularly of the donor, so you have abnormal umbilical artery, Doppler or ductus venosus or cardiomegaly, and then stage 4, you have hydrops of the donors, and stage 5, there's of one opposed to it, similar to the TGS staging. And there are other ultrasound features that you see in these pregnancies, and it's important to know them because sometimes this is the original referral if people are not monitoring the MCA peak systolic velocity routinely. So the starry sky appearance of the liver, as you can see on the right-hand side here, so darker with bright or white dots. And this is the white or the bright dots is the portal veins or the venules, and the dark, the liver parenchyma, because of the congestion of the liver, while on the left-hand side, the placental dichotomy, you can see part of the placenta here is quite thick and white or echogenic, that's often the donor or the anemic twin, and on the right-hand side, thin and dark or hypoechoic placenta or the recipient. How common is TAPS? Well, it depends on which diagnostic criteria you use, and we published this paper last year, where if you use the original, traditional diagnostic criteria, 1.5 and 1, the incidence of TAPS is about 8% of the monochorionic twin pregnancies. If you use the Delphi criteria, which, as I mentioned earlier, identify the more severe form of TAPS, so that's about 6% incidence. And if you use the delta and CA peak systolic velocity, so the discordance, the 0.5 moment is about 16% and 0.3 is about 19%. So if you use this German criteria of 0.37, you would almost label 1 in 5 of monochorionic twin pregnancies as complicated by TAPS. And regarding the outcomes, TAPS is associated with increased risk of perinatal mortality and morbidity, and that varies between spontaneous and post-laser TAPS. It seems that the risk of perinatal mortality is higher in the post-laser TAPS compared to the spontaneous TAPS, and it also seems that the anemic twin does worse or have higher risk compared to the polycystemic twin, as you can see from these figures. What are the risk factors? Which the pregnancies that have even higher risk of perinatal mortality? Obviously, the donor twin, as I mentioned, is higher risk. The TAP stage, indicating the severity, and the gestational age of delivery because of the prematurity. What about the long-term neurodevelopmental impairment? And that's defined or includes cerebral palsy, low IQ, bilateral deafness, and blindness. And again, if you look at spontaneous versus post-laser TAPS, so the incidence of long-term neurodevelopmental impairment is about 9% or less than 10%. And again, it seems particularly in spontaneous TAPS, the anemic twin is have worse outcomes than the polycystemic twin. And a very interesting finding that you need to know is his risk of bilateral deafness, which is reported in 15% of TAPS donors. The other thing is the brain abnormalities, and this is certainly 2 cases that I came across. So this case had TAPS at the same time as a selective fetal growth restriction, and often actually the smaller twin is the polycystemic and the larger twin is the anemic twin, and the larger twin, the brain, as you can see here on the right-hand side, the posterior one of the lateral ventricle, you see the increased echogenicity, periventricular echogenicity, and the MRI confirming the periventricular white matter abnormality, and the parents opted for selective cord occlusion of this twin. Another case of post-laser TAPS, so TTS at 18 weeks, had laser, post-laser TAPS 20 weeks, and repeat laser and intrauterine transfusion. And this is the follow-up. This is the brain, and you can see this is unilateral ventriculomegaly and intraventricular hemorrhage, and you see here the MRI confirming that. And again, the parents opted for selective cord occlusion of this affected twin. And it's important that we highlight this finding that we reported is this larger size discordance in TAPS, and whether that's a result of the TAPS or actually that there is an association between TAPS and selective fetal growth restriction. But certainly if you see the weight discordance significantly higher in the pregnancies with TAPS compared to the uncomplicated monochorionic twin pregnancies, and also, as you would expect, the gestational age of delivery was significantly lower, and therefore there's increased risk of prematurity. Just to highlight that we published on the perinatal outcomes of these pregnancies in a meta-analysis in a wide journal, and many outcomes according to spontaneous or post-laser, according to management. I'm not going to go through that because of don't have time, but just to highlight one of the key findings is the fact that the post-laser TAPS tend to have worse prognosis than the spontaneous TAPS, because obviously there is this TTS component as well. Presentation of TAPS can be in a number of scenarios. So the commonest is the post-laser TAPS. As I mentioned, it could be also spontaneous TAPS, and it can also coincide with TTS. And I've seen a number of cases, and that's also reported in the literature, that TAPS can coincide with TTS. So this is the typical or the commonest post-laser TAPS. So this is the TTS with a typical polyhydramnios, oligohydramnios, extended bladder, and the recipient stuck twin, the donor twin, have laser, and a week later the TTS resolves, but you have TAPS, where you can see here the middle septal artery peak systolic velocity, and you see on the graph the discordance and MCA peak systolic velocity, and this is a repeat laser, and you see after that the TAPS improves. The follow-up scans were fine. There was no recurrence of TTS or the TAPS, and the MRI at 28 weeks was normal, and the babies had good outcomes. Another case, spontaneous TAPS, so followed up in a local hospital and referred at 30 weeks. The only thing that the early ultrasound scan, there was a size discordance of 15%, which is not unusual. And on that day, there was high drops of the twin 2 with anemia, so high MCA systolic velocity. And the recipient of the other twin had low MCA systolic velocity and had the starry sky appearance of the liver. And also you can see the placental dichotomy. When she arrived, already the fetal heart monitoring was abnormal, and therefore there was the decision we decided to deliver, to give steroids, magnesium sulfate, cesarean section, and hemoglobin. You see the anemic twin had the hemoglobin 3 gram per deciliter, polycythemic 26 gram, anemic had blood transfusion, polycythemic exchange transfusion, and the brain imaging was normal. The last presentation I'm going to show you is this TAPS which coincide with TTTS. You can see here, this is the typical TTS with polyhydramnios, oligohydramnios, stuck twin, bladder is not visible, but when you look at the MCA peak velocity, you see the diagnostic criteria of TAPS, and you see here the placental dichotomy. And then after the laser, the TAPS also improves, as well as obviously the TTTS. And she delivers the babies at 31 weeks, and they're doing very well. When does TAPS occur, or the gestation age diagnosis? It's important because we need to know when to monitor for TAPS. So this is the data from the TAPS International Registry, which included a large number of centers and nearly 400 cases of TAPS. And you look at the spontaneous TAPS, and it can occur as early as 17 weeks and as late as 35 weeks. And therefore, we need to monitor for TAPS throughout the pregnancy. What about the post-laser TAPS? Well, 3/4 of cases of post-laser TAPS occur within 4 weeks after the laser. However, it can actually occur up to 17 weeks after the laser. And therefore, we need to continue monitoring throughout the pregnancy after the laser. Management of TAPS, there are 5 options. Either expectant management, particularly if you have a stage 1, for example, with mild TAPS, or preterm delivery, particularly in advanced gestation after a course of steroids, or laser surgery, similar to what you do for TTTS, blood transfusion for the anemic twin with partial exchange transfusion of the polycythemic twin. Certainly, my experience with it is that it's not, I don't think it's a good option, or selective reduction of termination, where particularly if there is discordant anomaly, and particularly at early gestation. And this was the 3 papers that were published from the TAPS registry last year on spontaneous TAPS or post-laser TAPS and outcomes according to the management. So I would recommend you to read them if you are interested. Just to highlight that the fact that perinatal mortality, and according to the various management options, you can see that there's not sort of huge difference among the various options. And what we noticed from the data from the TAPS registry, that it seems that the treatment of TAPS differ among the fetal therapy centers, but it seems that laser surgery is probably the most frequent treatment option. As I mentioned earlier, we don't have evidence from randomized control trial, but the TAPS trial has started. It's a randomized control trial that randomizing stage 2 TAPS, whether spontaneous or laser, between 20 and 28 weeks, to either laser surgery or standard management. The main outcome is gestation age of birth, but also looking at the neurodevelopmental outcome at the age of 2. Regarding the natural history, and it's important because that feeds into the debate whether we should monitor for TAPS or not, and also the controversial evidence of the TAPS presentation. It's important to know whether it's spontaneous or post-laser TAPS. Not all cases of TAPS do progress. And certainly there is a significant proportion, up to 40% of these cases that would regress, and about 10% that remain stable. The progression rate, once you take into account that there will be some that needs intervention, immediate intervention at presentation, there was about, let's say, 20 or 25%. They progress to a more severe form of TAPS. The monitoring, which is a controversial topic, certainly in the ISWAC guideline, we did recommend that we should be monitoring for all monochorionic twin pregnancies, including the uncomplicated monochorionic twin pregnancies from 20 weeks, that we record the MCA peak systolic velocity to monitor for the development of TAPS. And the FIGO guideline is also consistent with that, but I'm also aware that that's not the case in other guidelines, including the American guidelines or even the NICE. NICE guidelines had their update, which was published in September 2019, and I was a member of the committee. And certainly we had a lengthy discussion whether we should recommend routine monitoring for TAPS and take into account the lack of evidence or strong evidence, robust evidence on the natural history or the best management of these cases. Certainly the recommendation was the fact that we should be monitoring for TAPS using MCA peak systolic velocity from as early as 16 weeks weekly in all cases that had laser for TGS, and if there is any deviation from normal. So if you have selective fetal constriction, if you have abnormal umbilical Doppler, unexplained polyhydramnias or cardiomegaly or hydrops, in this case, we should be monitoring for TAPS weekly. My final point is about prevention. Can we prevent TAPS? And we have evidence from randomized controlled trial. There's a Solomon trial. That the fact that technique of laser, if we do the laser of the entire equator in monochorionic twin pregnancies complicated by TAPS, you reduce the risk of post-laser TAPS. So this is the selective approach. You identify the anastomosis and you use a laser to photocoagulate the anastomosis, while actually laser of the entire equator is that once you identify and you laser the anastomosis, you actually use the laser to draw a line across the vascular equator. And in the Solomon trial, the risk of TAPS or recurrence of GTTS was significantly lower, so 4% versus 22% in the selective laser approach. And therefore, using the Solomon technique does reduce the risk of post-laser TAPS. So really my take-home message is that TAPS is associated with increased risk of perinatal mortality and morbidity, as well as a neurodevelopmental impairment and brain abnormalities. TAPS is a discordance in MCA peak systolic velocity that's different from TDGS, whereas polyhydramnias, oligohydramnias sequence or amniotic fluid discordance. We need to acknowledge that the role of Doppler on monitoring for TAPS is more controversial compared to the TDGS, where most guidelines do recommend that we monitor for TGS from 16 weeks every 2 weeks until the end of the pregnancy by measuring the deepest vertical pocket. And therefore, we need obviously more research, but it's important that we are aware of the diagnostic criteria, aware of how to monitor for these pregnancies and the management options. And thank you for your attention, and I'm happy to take any questions.
Thank you so much, Asma. I think that might have answered a lot of the questions that our audience has in the management and diagnosis of TAPS. So thank you so much for being so thorough. We're gonna have the questions at the end of the next presentation. So the next of our next presentation is recorded. The presentation is done by Dr. Ozan Turan. He's going to be talking about TRAP-sequent current status of evidence. About Dr. Turan, he is the director of the Fetal Therapy and Complex Obstetric Surgery, and he is a professor in obstetrics and gynecology and reproductive sciences in the University of Maryland School of Medicine. He is also the vice chair of obstetric services and division director of maternal fetal medicine in that institution. He has conducted extensive research in fetal monitoring and Doppler ultrasound, and he has developed 3D and 2D ultrasound methods that measure the fetal adrenal gland to predict preterm labor, which is quite fascinating. So we're gonna let the presentation of Dr. Turan run right now, and then we'll take all the questions from the audience. Thank you.
Good morning. I would like to congratulate our dear colleagues at Baylor for organizing this nice webinar, and thank you very much for the invitation to Dr. Cortez. Today, I'm going to talk about TRAP sequence in the next 15 minutes. TRAP sequence, twin reverse arterial perfusion sequence, is a complication of monochorionic pregnancies. There is two twins. One of them is a normal innocent one called as pump twin or normal twin. And the other one on the top, as you see in this video, a parasite twin, an amorph shape mass, could have legs, but characteristically doesn't have a heart. A pathognomonic finding is a reverse flow to this mass, the trap. As you see in this clip, the flow is blue, which is away from the probe. It should be an arterial flow from actually the mass to the placenta, but it is reverse. Therefore, it's called as reverse arterial perfusion. The incidence, traditionally known as 1 in 35,000 in pregnancies and 1% in monozygotic twins, recent data show that this incidence actually much higher, about 1 in 10,000 in pregnancies and 2.6 in monozygotic twins. Why is it important? Because pump twin is at risk of congested heart failure and death. In addition, polyhydramnios, preterm labor, early rupture of membranes, hypoxia, and FGR are the other risk factors for the pump twin. Intervention management are three managements reported in the literature: expected management, prophylactic intervention at 16 to 18 weeks, prophylactic intervention at the first trimester. I will try to concentrate on more the prophylactic intervention today, next 15 minutes. The expected management, the aim is to avoid risk of intervention. Many other criteria were used to identify who's at risk for complication or what will be the threshold of intervention using pathologist specimens data, a cardiac to pump twin weight, which is more than 70% is high risk for death of pump twin. And since it is difficult to calculate weight, a cardiac pump abdominal circumference ratio was used. Again, umbilical venous diameter ratio were used, but none of them are actually a good sign or predictable value. Prophylactic intervention at 16 to 18 weeks. The aim of this intervention is the waiting to membranes to fuse and reduce the risk of rupture membrane or miscarriage. This data came from the early amniocentesis data. Therefore, the protocol to prophylactic intervention 16 to 18 weeks has been almost established in TRAP management. Whatever the source do you use for prophylactic intervention at 16 to 18 weeks, they work well. The most common ones is in this slide shows as cord laser coagulation, cord bipolar coagulation, intrafetal laser or intrafetal radiofrequency, all has the similar success rates, about 70 to 85%. I'm not going to go in detail the prophylactic intervention techniques today because of the time limits. So with this protocol, many of us saw different complications of TRAP sequence. Therefore, Elizabeth did a nice study and tried to look what will be the outcomes by using these algorithms. I will explain to you this graph. In 3 groups of patients were identified. One of them is the fetuses, the pump twin, died during the waiting time to 16 to 18 weeks. This is group A. Group B is the flow to the trap sometimes stops itself. Group B includes those cases, and group C, cases who reached the 16 to 18 weeks and had planned intervention. And they look at the rate of demise of pump twin. As you see in the slide, 33% of pump twin demised while they are waiting to 16 to 18 weeks. And about is about 5 out of 2 case stop flow to the trap while they're waiting for 16 to 18 weeks, and 2 of them only reached the survival. Therefore, the risk now, if we combine both groups, is about 46%. When they reach to the 16 to 18 weeks, actually the system works well, and 90% of the trap pump twin survived. Then, if you combine all these numbers, the demise risk is about 54%. And the authors demonstrated that there is no first trimester marker for predicting mortality. So is it true if we do the procedure early, we increase the risk of miscarriage? Professor Nikolai's group did a nice study. I'll try to explain this graph to you. On the x-axis, the time of the intrafetal laser. On the y-axis, you'll see the time of the delivery. And if you concentrate on the first and second trimester procedures, as you see, the probability of reaching 32 weeks is higher if you had the laser earlier compared to later. And that probability increases for 34 and 36 weeks even. So this study showed that actually earlier the intervention is actually prolongs the pregnancy. Professor Nikolai's group 4 years later, they published their TRAP results. And they found that if they do an intrafetal laser at first trimester, 67% survives, or 1/3 demise. And if they wait until 16 to 18 weeks, is about 1/3 of the trap stops its flow to the trap twin, then of those, the 50% actually demises. The remaining who reaches the 16 to 18 weeks, the success rate for the procedure is about 80%. If the trap diagnosed at 16 to 28 weeks and had an endoscopic or intrafetal laser, the success rate is about 80%. 4 cases in this series had expected management and delivered without any problem. When the trap diagnosed at 16 to 28 weeks and during follow-up, it stops the flow to the trap, 75% survived. This study showed that the risk of cessation of blood flow to the trap is higher in first trimester compared to second trimester. And the success of the intrafetal laser is about 66%. While we were ready to do all intrafetal laser for traps after this study, Bone Group published their first result of 12 trap intrafetal laser, and they found that the survival rate is about 58%. When they look at the gestational age of intervention for survivors and that pregnancies, they found that the survivor had a later gestational age, about a week difference. And of course, the size of the trap is bigger in the death group. However, multilogistic regression couldn't identify a single predictor to identify risk factors for death. Recently, Dr. Hacker's group published their first dozen of intrafetal laser at first trimester. They found that actually survival rate of 92%, and gestational age of intervention was 13.5, same as the survival group of bone group. It could be surgeon's experience, it could be instrumentation, patient selection, or just the gestational age is later is better. However, until today, we do not have good information, randomized trial for this management of TRAP. Dr. Elizabeth Levy started a multi-center open-label randomized controlled trial to compare the early and late intervention, and that study started recruiting in 2016. And as far as I know, there are 2 NAFNET centers are actually recruiting for Dr. Levy's studies. So what we should be doing until this study is answered? Expected management generally comes from patient's condition. Sometimes if the patient is, after counseling, patient doesn't want a procedure. We have a similar case as a very slim patient, and it was an IVF pregnancy, and she said, no, I'm not going to put my babies at risk if there is no real risk. Another case we had as the BMI of 55, we couldn't really find an access point to safely do the procedure, and the patient actually delivered at 34 weeks without any intervention. The counseling for the patients at this time, I counsel them, if I do a procedure at first trimester, the risk of demise of pregnancy is about 30%. If I don't do 30% of cases, the flow to the trap stops, and of those, half of them only able to survive. And if you reach to 16 to 18 weeks, whatever the method generally I use, bipolar or intrafetal laser, the result is good. I would like to just briefly show you a new tool, high intensity focused ultrasound, or HIFU. Our Japanese colleagues published their first experience of 6 cases for TRAP sequence. As you know, HIFU is on a study in England for doing an early laser. What they found is only 3 cases had a full occlusion, and those 3 occluded cases, 2 of them actually demised, and 3 of them couldn't have occlusion. In addition, patients had significant burns, one of them second-degree burns, and I want to highlight the BMIs is about, as you see from here, is pretty unusual for us. HIFU technology probably require more advancement to be able to use in our patient population. In the last slide, I would like to discuss a little bit monoamniotic traps. Until this slide, every data that I show you today is related with the monochorionic diamniotic traps. Monochorionic monoamniotics are different because of the risk of cord entanglement. I use length of cord as a point of discussion for the patients. If the cord is short and trap is not moving left to right, I go with the standard method and counseling. If the cord length is long or normal, I use a standard method and combine with transection of coagulated cord by using a fetoscopy, either laser or scissor. In the literature, there is not big case studies for monoamniotic traps, but the case reports showed about a 75% survival. Again, I would like to thank for the invitation. Currently, I am on vacation, and if I have a good internet connection, I'll try to connect for questions. Thank you very much.
Thank you so much for such a thorough presentation, Dr. Turan. He's connected right now. Hopefully we'll be getting a good internet connection for him so that we can have a discussion about trap sequence. But before we talk about trap, I would like to ask Asma some questions about TAPS. So we heard about the guidelines, and I think that provides a lot of clarity, and they're very helpful for the clinician to have in the regular practice, just to make sure that these patients don't fall between the cracks and they have the proper follow-up. My question to you, Asma, is about one of the results that you showed based on the outcomes of TAP pregnancies. It's clear to me, based on the perinatal mortality results, that the worst situation when you have TAPS is not to do anything, because the perinatal mortality in that situation is 17%. And I'm just talking about the very clearly severe forms of TAPS. And then the results when we do a laser versus when we do other alternative treatments, such as intrauterine transfusions, they have very similar results based on your experience. The perinatal mortality for those two treatments was 18%. Exactly the same for those two alternatives. So I wanted to ask you and to comment about which markers from your clinical experience do you take into account when you're deciding whether to do nothing, expectant management, versus when you're considering to do any intervention such as laser or intrauterine transfusion. And also there's a question from the audience asking why TAPS post-laser is so different than the natural form of TAPS. So it's two questions there.
Okay, that's fine. So maybe to answer your question first, which I think is really important question. And I think it varies, I think, from one center to another, but I think most people would intervene if you have evidence of compromise of either twin. And that would be abnormalities in umbilical artery Doppler, or ductus venosus or cardiomegaly, for example. Of course, the cases that TAPS that coincide with TTGS, the management will be according to the TTGS. And so you will have to do laser, for example. So that would be the criteria for intervention. What intervention you would do depends on the gestational age and also on the technical feasibility. Certainly, where I work, I think laser is probably the first line. Certainly the cases that we've done transfusion, exchange transfusion, certainly the outcomes have not been very good, and therefore we reserve the transfusion only if after the laser the anemic twin has not recovered and is still significantly anemic. There's still sort of evidence of compromise. In this case, we would do post-laser transfusion, and often you need only one transfusion because you corrected the cause. You stopped the anastomosis. So that's your question about what criteria to intervene and what intervention. Of course, I mean, if it's 32 weeks, you're not going to do a laser. Most likely you will plan preterm delivery after a course of steroids and magnesium sulfate. And for the second question, which is why post-laser TAPS has worse outcomes than spontaneous TAPS, because don't forget, you still have the TTGS outcome. So this pregnancy, if TAPS did not occur, we still have obviously the potential complication or the morbidity associated with the TTGS itself. So I suspect that's why the post-laser TAPS have worse outcomes than spontaneous TAPS.
Mm-hmm. I think that you're absolutely. Probably it's related with the underlying condition of TTDS that already deteriorated those babies prior to the laser. And we follow a very similar algorithm in our practice. So when we have TAPS, if it's severe enough, we typically offer, our first choice would be laser rather than IUD, but obviously we individualize the treatment in each one of the cases. Raman, what do you do in Los Angeles for TAPS? Do you have any comments on that? Probably.
First, thank you for the wonderful talk, Asma. For TAPS, we are very strict with the diagnosis, and so we still follow the staging system. If they're at an advanced stage and it's relatively early in the pregnancy, then we will offer laser. But we have found that the number of patients that are in that group is actually relatively low. And so if you have TAPS based on just the middle cerebral artery discordance, but there's no evidence of hydrops, no other Doppler abnormalities, then we will just monitor the pregnancy and try to get to a reasonable gestational age for delivery and avoid the risks of laser. So we have found that we end up doing much less interventions. I can't tell you whether our outcomes would have been better if we had just done laser on everybody, but we could potentially avoid the risks of laser. That's why, a randomized controlled trial in this area would be a great idea, and I'm happy that that's ongoing.
That's great, thank you. I mean, I think what I would like really to maybe bring to this discussion is the diagnostic criteria, because I think that's quite key. Because if you use the criteria that were proposed by the Dutch group and the German, which is just relying on the discordance alone, I think you will end up by diagnosing many cases of TAPS. I think the majority of them do not necessarily progress to more severe TAPS, and probably the mortality and morbidity is much less. Compared to, for example, if you use Delphi criteria, which is from a fetal medicine expert or fetal therapist, I think this is the cases that really need to be monitored and be considered for intervention. But on the other hand, there will be another view of the fact, okay, well, so what if you diagnose or label many cases of TAPS because you monitor them and you can only intervene if it's necessary. So I think this debate, I think, is really important, and maybe just it'll be interested to hear your views as well.
Yeah, I agree with Raman. I think that it's a very good initiative to have that RCT. There's very poor level of evidence on what exactly needs to be done with TAP pregnancies. So we were looking forward to reading that paper whenever it's published and the study is completed. Dr. Duran, are you able to connect with us? I'm going to ask a question about TRAP sequence.
Can you hear me?
Yes, we can hear you well, Dr. Turan. So I think it's very interesting what you presented about the differences in gestational age for the treatment of TRAP sequence, and definitely that difference and that lack of evidence is present in the need for a randomized control trial, the one that Lisbeth Lewy is conducting from a multi-center perspective. And this is one of the other studies that we're very much looking forward to getting the evidence provided by that study. I wanted to ask you, how do you manage in your institution TRAP sequence cases? Do you offer like such early intervention as 12 to 14 weeks as one of the arms in the TRAPPIST trial? Or do you just go like after 16 weeks, like most of the centers?
With the patient, whatever I said during the presentation, 1/3, if I do the procedure, 1/3 of the pregnancy will demise.
Ozan, I think that your connection is failing a little bit. It's kind of coming in and out. So we're gonna try and see if we can recover your connection. Because so far, Ozan, so far,
and good evidence.
Ozan, I think your connection is very unstable. It kind of comes and goes. So let me just ask that question to Asma and to Raman to see, and Rupali, since we work in the same institution, I'm sorry that I'm not asking you directly, but I also would like to hear your comments on this topic, Rupali. So question is, gestational age for treatment for TRAP sequence, what is your standard in your centers? So Asma, we can start with you.
Okay, fine. So we are taking part in the TRAPPIST trials. So we are randomizing these women either for early intervention or delayed intervention. But if the women don't want to participate in the trial, we do offer first trimester intrafetal laser. It's a simple technique. Yes, there is a risk of demise of the pump twin, but the risk is relatively small, and we published our data, and the survival was nearly 80% if you do first trimester intrafetal, so in early intervention.
That's very high survival rate, Asma, 80%. That is compared with the 58% rate that Ozan was giving us in his presentation. So is there any particular reason that you think that your survival rate is much higher?
I mean, in fact, actually, if you look at the literature, I think most of the studies that did even sort of cord occlusion on laser would quote 70 to 80% survival. The question is that how you, whether when they do the analysis, they take into account that between the first and the second trimester, there is a significant proportion that actually when they come back, already the pump twin have demised while you're waiting between the first and the second trimester. Or when the researchers doing the analysis, they will just look at the cases of TAPs that had, let's say, the laser or the cord occlusion, and they report on the survival following this intervention. So I think it depends really how you do the analysis. I think that the King's study, the one with by Elizabeth and Kypros, they actually took it from the first trimester. So they've been diagnosed in the first trimester and then had the one that had intervention later or waited until 16 weeks. There is a significant proportion, about 50% or so, when they come back, they actually demised.
I see.
So it depends, I think, on how you do the analysis.
That would explain things. Raman, what do you do when you have a TRAP sequence? What gestational age do you do surgery?
So I think we do things a little bit differently. Just because they have TRAP, we do not offer cord occlusion. We have a selection that we would basically offer the procedure if they meet a certain criteria. So we published this in 2006 in the Gray Journal, and we subclassify patients with TRAP. So just because they have TRAP alone, we will expectantly manage them. But if they meet one of four criteria, so if the abdominal circumference of the acardiac is greater than that of the pump twin, if the pump twin has critically abnormal Dopplers, umbilical artery, just like the quinterval staging system, umbilical artery, ductus venosus, or umbilical vein. If there is polyhydramnios in the pump twin, or if there is a short cervix and we're worried about preterm labor issues. If they have one of those things, we'll offer cord occlusion. If they don't have any of those things, we will do serial monitoring. And we found that there are some patients that cross over, and if they do cross over, then we'll offer the cord occlusion later, and we could do cord occlusion at 20 weeks or 22 weeks. But many of those patients, especially those with a small acardiac, why imposing the risks of a procedure and procedure-related complications if these acardiacs are small? Many of them will self-occlude. And so we've basically have this triage system for TRAP sequence.
Mm-hmm. Sounds very similar to what we do. Rupali, do you want to tell them what we do?
Yeah, I mean, we do something very, very similar. I will say I come from a jump in and do everything aggressive training to now the more modified watch and see training. So I feel like it's nice to get the perspective on both sides. So I do agree with the idea that if you see it, that they're more likely to end up with intervention. Yes, as Raman mentioned, they're the ones that are really tiny, I understand. But typically when you see diastolic flow in that feeder vessel, you're going to end up intervening at some point or the other. So I see the argument as, if you're going to intervene, do it as early as you can to avoid any morbidity. But having said that, here at TCH, we do follow them and we look for signs of distress. So similarly with our echo, any signs that Dopplers are worsening in the pump twin, significant increase in the size. And I will say, of the ones that we followed here, none of them have had any adverse outcomes in watching. So in a way, I am a little more sold nowadays in the wait and see policy, because I feel like none of them that we've sat on have had any issues. That also does go to the fact that we do have good follow-up with these patients. And so that is obviously the key part of it. If you're getting a patient who's having to travel several hours each time for an appointment, and that's not convenient, socioeconomic barriers, maybe they'll benefit from an earlier intervention, but we haven't seen any morbidity from waiting. And definitely the advantage of waiting is also that you are not jumping in too early and having the risk of PPROM and the other adverse outcomes from early intervention. So yeah, we definitely wait and see unless there's signs of distress.
Wonderful. Last question, because we're running out of time. I don't want to leave this question not answered, because I'm sure that many of us are thinking about that. So I want to ask to the three of you guys, what do you do for selective fetal growth restriction type 3? And that's probably a very long answer, but in just a nutshell, do you do surgery, yes or no? And they've been asking us, how often do we monitor these babies? So Asma, Raman, and Rupali.
You pray. They are quite tricky to manage, because often a lot of times the cord insertions are relatively close to each other, and therefore laser is technically very difficult, and I think it's associated with high risk of demise, and whether you would be able to achieve technically a successful laser or not. So certainly we would try to avoid laser. And interesting to see whether Raman have different views. If there's high abnormal ductus venosus, or sort of suggestion that there is imminent risk of demise of the smaller twin, we do offer cord occlusion. Otherwise, we expect the management, and we deliver at 32 weeks latest, or early needed. Yeah, okay. Elective, because of this potential unpredictable risk of demise of the smaller baby.
Thank you. Raman.
So we do not offer cord occlusion or laser for type 3 SIAGR. So basically, for SIAGR, the only cases we offer fetal treatment is for type 2. We found, we published a study, I think a year or two ago, that half of the type 3 SIAGRs actually do very well. And it's the other half that deteriorates. So when we lump them together, the overall numbers are not so good. But if you actually look at them separately, there's a group that do very well with over 95% dual survivorship. It's the other group that don't do well. Now, the problem is we don't have predictors of which way you're going to go. So you have to monitor them with serial evaluation. And each one of us have our technique, whether it's weekly or twice weekly in Dopplers. But that other half that don't do well, some of them end up developing overt twin-twin transfusion syndrome, and then you follow that road. You would manage them like all the other TTS cases. And some of them develop type 2 SIAGR, and then we manage them like our type 2s. So that's how we have managed type 3 SIAGR, serial scans. If they stay type 3 SIAGR, they seem to do pretty well. The average gestational age of delivery in that group was actually 35 weeks. It was the ones that evolved into TTS or type 2 SIAGR that did not do so well. And in those groups, we had to follow the algorithm for those two entities. That's how we manage these patients.
Raman, I can see the future reading a paper of yours with type 3A and B. I see the future.
I wish we could predict. That was so we did publish a paper on type 3 SIAGR and the natural history of expectant management. And that was a year or two ago, and that's why I'm quoting you this information. But we couldn't find who would be the 2A or 3A or 3B. I wish somebody could help us figure that out.
Thank you. And last but not least, Rupali, you can tell them what we do in our institution.
Yeah, thank you, Magda. And I'll try to be really quick. But so we don't offer any intervention for type 3s, but we do monitor them a little bit more conservatively, similar to type 2s. So once they hit viability, and that's a very vague thing to say, I know, but we do have counseling with neonatology to determine survival rates at different gestational ages. So that's important for us for them to meet neo. As they get closer to 28 weeks, we do increase their frequency of surveillance. But I do want to give a shout out to Ahmed Nasser, one of our colleagues, and he's very interested in this group. And he, at some point, I'm sure he'll get this publication out there, but he's been working on it for a while. We found actually quite a few of our type 3s actually end up having normal Dopplers in the third trimester. And so they do end up doing pretty well. And that's why they are able to get further in gestation. So that's the other thing about them. We follow them so closely that we have noticed a big part of this particular subgroup that do well is because their Dopplers do normalize. But yes, we're very conservative in monitoring them very frequently. And there was a question I know about cord occlusion. We don't offer cord occlusion in the state of Texas, unfortunately, with this new SB 8. So that's not something we would be considering. Yeah.
All right. So thank you so much for answering those questions. I think that these topics are really fascinating. So it's hard to just stay on the very limited amount of time. So I want to invite everyone for our next webinar, which will be on November 6th. It will be at 9 a.m. Central Standard Time, and the topic that we will be covering in our next webinar will be neural tube defects. So we'll be talking about fetoscopic expanded fetal repair, open repairs, etc. So we hope that everybody will register for that webinar. It will be the same system that we have used for this one and the previous one. Thank you all for being here and participating in this webinar. Thank you so much for all the speakers, Dr. Turan. Thank you so much for making the effort of connecting while being on vacation in the coast of Turkey. Lucky him. Thank you so much, Raman and Asma and Rupali, for giving excellent presentations. And I hope you guys have a wonderful weekend.